Okay, I'm going to demonstrate the AMSA injection, and the landmarks for this injection are the premolars and the midline here, and you want to go about halfway between the pregingival margin and the very middle of the palate, kind of where the horizontal and the vertical planes meet. And I'm just going to feel around until I find a nice springy spot, and right here feels nice and springy. So that is going to be my site. Okay, so you're going to use the pressure anesthesia. I've applied the topical onto this same Q-tip, and I'm just going to be pushing very firmly for at least a minute. 2 minutes is better. And this injection is going to get the premolars and the anterior teeth, the incisors, and the canine on the site of injection, and they're going to become anesthetized pulpally. And it's also going to get the palate from the molars to the central. So it gets the entire side of the palate of the tissue, and it gets pulpally the premolars and the anterior teeth. And on the facial side, it only gets the gingiva on the teeth that are also getting pulpally numb. So it gets the gingiva of the premolars and the canine and the incisors. It does not get the lip. So that's one of the advantages, because the patient is going to be able to smile and the lip won't be numb. So I'm using lots of pressure. The depth for this is going to be about 4 millimeters. Hold the Q-tip in such a way that you've left an open path for the syringe to come in and you're not blocking your own way. So I'm going to sneak it in. As soon as I'm pretty close, I'm just going to hop out of the way and go where the Q-tip was, and I'm just going to start giving some drops. I haven't aspirated yet. I'm just giving some drops on my way in, and now I've contacted. So I'm going to aspirate and continue. And you're just going to start to see a lot of blanching. And you have to go pretty slow on this one, because we're going to end up depositing 3/4 to 1 entire cartridge on the palate. So you have to go nice and slow. You don't want to get more than 1/3 of a cart in less than a minute. So that's about the rate, 1/3 of a cart to a minute. So you can start to see the blanching. I'm going to move the Q-tip. And I've already told the patient that they're going to stay open for wide for quite a while, and it's going to take, a few minutes for this one, so that they know. And after about 1/3 of a carp, I like to just kind of stop for a minute and let it dissipate. You don't want to see the ballooning. Doing okay, Julie? And so the blanching needs to spread all the way up there to those front teeth and all the way back to the posterior. So the entire side of the palate is going to be looking very blank. So I'm almost done. And I think we're just about good. It needs a little bit more in the posterior though. I don't know if you can pick that up on the molar teeth. It's not quite as blanched as it is up there on the anterior. So I'm going to wait and see if that spreads a little bit. If not, and if she needed a little bit more soft tissue anesthesia, I would walk it back there. Okay, but the most important thing is that it got numb all the way to the anterior. So when you're done, you should see a little bit of blanching on the gingiva up in the front, and you can barely see it on her. I don't know if the color's going to show, but it does look whiter up here in the anterior and premolar area. And then go ahead and open. You can see it, but the blanching needs to spread from about here all the way back.
The middle there.
And so again, we're coming. We kind of, as you said, park the bevel against the bone, so it's not coming across like this where we would hit the tip first and
Correct.
The bevel wouldn't be against the bone. We want to kind of make sure that that angle of the bevel is going to be right against the bone, as you mentioned.
And then from there, just same thing. Just make your penetration, and it will be fairly shallow. And I'm just going to advance till we have contact. And then for this one, we have our base unit set on the STA setting.
Okay.
And we may or may not hear the same signals we get from the dynamic pressure sensing indicators.
Mm-hmm.
And we've got dense tissue. That same pressure can build up, but it's not necessarily a component of this
Do we have
injection.
a cotton tip applicator I can borrow real quick?
Mm-hmm.
Just to-
And that's why, like in our kit, we keep the sterile cotton swabs, a couple in a pack all ready to go.
Yeah, that's
So
really smart.
if we have any backflow, we can be collecting that, and they don't have to deal with the taste of it.
I can see that blanching that you said it was going to occur. It's going all the way up to the bicuspids.
Now, through the course of this injection, we are going to see that pattern, extend oftentimes right to the midline and back, approximating the mesial lingual of the first molar. Everybody's going to be a little different. If your blanching pattern didn't go in both anterior and posterior direction, then you could choose another site, just step a little more distal if it was
Now this
not
seems
flowing
like,
distally.
this seems like an injection, this whole part delivering this, that would be really difficult with a manual syringe compared to just letting the computer do it nice and slow and steady. This seems hard to do with a manual one.
Well, and if we remember back to that feeling of what it feels like to give a nasopalatine, we're in that same dense tissue, so you have to maintain that pressure to keep the flow going throughout the injection, and that's really tiring. And one of the other things I've always found it interesting, the same thing with the greater palatine, you can see the pinking right around your penetration site. For whatever reason, it's like the tissue always kind of fills in there last. Again, we've got a good blanching extending in both directions. And as we continue with that, we're going to have that fill in around at our penetration site as well. Now, depending on what drug we're using, we're going to be using anywhere from a half a cartridge to a full cartridge.
And you base it less on how much has gone from the cartridge versus the blanching pattern.
Correct.
The blanching pattern basically tells you when you're done here.
And anytime you start seeing it actually dripping back out your penetration site, the tissue's just not accommodating anymore. Solution. The other thing that we tend to notice with this one is as you retract the tissue back, we'll see this blanching, it is diffusing through into the buccal structures. And for some individuals, we'll see the same blanching on the buccal tissues at the end of this injection. And then, that's a phenomenon where we're getting lingual gingiva, we're getting pulpal structures, and we're getting facial gingiva without getting any labial anesthesia, which, if I've got my terminology right, allows you to see your zenith line.
Wow. Nice pull.
Ooh.
It's a state board question. You're right. I see it up to the second molar now. I'm just gonna make sure I don't.
And it's just starting to get, it's just starting to get, okay. And if you can turn
Want
to
to
the
turn it
side,
this
see if
way?
we can get it. And you can see the blanching from the mesial of her second
Oh,
molar
yeah.
through to her first bicuspid.
Look at that.
And that's as textbook as this gets, folks.
That's
in fact, from this view, see how look right in the palate at the median suture?
right.
You can literally see the
Yeah, it
pink
stops
half and
right
the
there.
blanch
You can
half.
see
It
exactly
stops
where
right
that
at the
stops,
median
and it goes
suture.
back to the second molar.
And then here we've got a
You
diffusing
should have
clear
bet
through
me
into there.
$20 that, and said, "Do you think it will blanch
But-
on the facial?"
But I would feel, confident in doing anything in particular from probably through her first molar bicuspids, and from a hygiene standpoint, we're going to pretty much get everything we need for doing.
molar as well without the PSA?
In your particular case, we see blanching clear back to there, so I think it's likely that you would also have some anesthesia in the first molar, and if we had extensive procedures, we would go ahead and supplement that with the PSA on
So
that
what
side.
what